All right, so welcome everybody. We got a small group, but I do want to play a game later today, possibly. How many are already PCMH recognized? Has anybody gone down that path yet? No. Well, you are. Oh, good. So we have one, and we have Kate. So we have two. Anybody else PCMH recognized or been through the process? You've been through, okay. So these are our experts. The rest of us are novices. And we're going to challenge the experts later after we go through this presentation and stump them, with questions that we may have. So my name is Angie. I live in Illinois. I have a company called Canopy Associates. And prior to that, I worked with 58 critical access and small and rural hospitals in Illinois. And then we had a bunch of clinics that were associated with them and then independents. I have been on the board of NARC, and I have been past president of NARC for, I think I sat on the board for 10 years before I left. So I have a lot of knowledge in clinics, but this is something that I will tell you hands down I'm passionate about. And why? Because it's the right thing to do. I grew up as a nurse in a trauma center, so when you have 700 to 900 beds of patients, it's very different than rural. And when I stepped into rural, it was, a whole new world. I actually was at a small and rural hospital with clinics that reported to me, and I was there 6 months before I ever understood what a critical access hospital meant, let alone a rural health clinic, and the world just changed from there. I live in rural. I understand the challenges of rural. And one of the things with my own provider, and I'm going to use these as examples, he is PCMH recognized. He is PCMH recognized through his system, Unity, and I'm going to share how that works for me, what I experience with that. So we're going to kind of touch on that, and then this is truly open, ask questions, everything. And I am being recorded, so hello to all of those that are watching the recording as well. All right, so some learning objectives. We're going to look at some of the key components. What does it really take to be PCMH? And this is whether you want to be PCMH-like or you want to go through that recognition accreditation process and who you want to do it with. And we're going to identify the benefits of this. And then we're also going to understand the role of the staff. And that, I think, is one of the biggest challenges. And that's probably one of the biggest challenges we face when we implement any kind of change. So patient-centered medical home, we know this stuff. We've heard this. There have been gazillion webinars. There's postings about this all the time. It's really organizing the patient-provider relationship, and you make them as one. So really looking at improving the healthcare quality, gaps in care. We've heard that, right? Social determinants of health. This all falls under PCMH. It's how we address our patients. Now, I will tell you, again, my provider, Dr. Drew, and I love Drew. He was actually a resident when I was house supervisor of the trauma center. So we've kind of grown up together, and now he's my doctor. My mom has breast cancer. He knows this in my records, and I'm like, how did you know this? And he's like, well, it says so right here. And he tracks, when she goes in, he will ask my mother even, because I'm on her records, has your daughter got her mammogram yet? So, it's just this holistic approach of he knows his patients. That's patient-centered medical home. When I come in, he knows me. He knows my mom. He knows our family history. And that's what we want to get to, are those gaps in care, and how are we addressing it? All right, accrediting bodies. If you do a Google search, this is what it says. HRSA contracts with NCQA, Joint Commission, Quad A. And then we have the compliance team, and then we have URAC. So there's many out there. And I'm going to tell you, I'm going to talk about two. I'm going to talk about compliance team, and I'm going to talk about NCQA, because those are the two I see out there. I am also going to tell you, Angie is very biased. I am a compliance team proponent. I promote them hands down. Yes, I have been a surveyor for them. Yes, I do survey for PCMH for them. But it's not because, I work with them. It's because it's the right thing. It falls in line with our daily functions. And that's what everybody needs to understand. There is just so many other processes out there and so many other companies, but you got to do what fits. You got to do what makes sense in rural. So characteristics. We have a personal physician. Mine is Dr. Drew. We have physician-directed team-based care. And when we think team-based care, a lot of people get very scared about this. A couple of years ago, when I worked in ICANN, I was the VP of Quality and Education and Compliance Officer. We promoted team-based care through a fellow, I believe his name was Dr. Anderson. And I had several of my hospitals take on team-based care and really start to implement that. And it was before PCMH really started to grow within our organization. It was before we became an ACO. But it really is, how does the provider lead the healthcare team, and how is he involved? How is he engaged in the daily activities of who is he going to see that day, and what does he need to know? And then it's whole person orientation. The providers are addressing the whole person. And then we have care coordination. Woohoo! Yeah, so if you want to ask me about something else, care coordination. All about PCMH, they all fall in line. And let me tell you, you guys are getting a bang-up job of all of this today because I'm talking PCMH, the next presenter is on care coordination, and then we're gonna talk about quality, and then we're gonna do a mock survey, and you're gonna find out you're already doing it. So, hey, it's a win-win. So quality and safety, let's look at some quality. What does the patient want? So in my record, it says that I want to drink more water. That is apparently my goal. It's been my goal in the last 3 years with the doctor because I drink 1 glass of water a day. I am a coffeeholic and I know it. And so on my records, he asks, how are you doing on your water intake? And I'm like, great. So again, it's looking at what are the patient's goals? What do they want to do? Enhanced access to care. And we're going to get into that a little bit. And, tomorrow I think we're talking about how you change some of the care and the scheduling with Jeff. And that will help build this piece of it. So again, you're getting the whole thing. So team-based care, how many do huddles? We got a couple over here that are doing huddles, a few over here that are doing huddles. Who doesn't know what a huddle is when you think about huddles? So when we do our huddles, that really helps solidify your team. Who's doing what for the day? Who's accessing those records? Who knows what they have? And how are we communicating with each other? So it's proactive. It's planned. It is scheduled. You do this consistently. We're looking at the delivery of care we are giving and making sure that we've identified the gaps in care of that patient. If I have a diabetic coming in, I want to know if they've had their hemoglobin A1C done. If I have a hypertensive patient coming in, I want to know if they're taking their medications, or they're not taking their medications, and why. We're looking at our policies, our procedures, staff, roles and responsibilities, as well as that communication process. If I have a patient that went and seen a specialist, I want to darn well be sure I've got that report, or I'm calling to make sure that I can get it. So when that patient comes in, they get the whole approach of care. And that takes us to care coordination, how we're tracking our patients. What are we doing to make sure that they are getting what they need? Both normal and abnormal results. When I come in and do a mock survey in a clinic, I look and see, did you do labs? Did you do them internally? Did you send them out? How did you communicate that to the patient? Is it documented? Again, if it's not documented, it's not done. So, and what did we do with that? Also with our specialists. We can send our patients to our specialists all the time. Are we getting those reports back? And I think that's the hardest thing to do is get those reports back. But then also, are you evaluating your specialists? How's your patients like them? Are they the ones that you should be referring to? Is there another option? Should you be looking at that? They may not like that specialist, so they're not going to say anything. We coordinate with our emergency department. Where's our patients going? Are they going into the hospital? Do we know it? Are we communicating with them? Are we talking routinely with the ER to look at our volumes, to look at any kind of out-migration? Our patients are going to the ER to be treated as a family practice, because they don't want to come to the office because maybe our hours aren't convenient for them. And that's something that we're going to look at. Are we making sure we're following up with those patients, that we're getting them scheduled for a follow-up post-ER visit? What happened? Did they get transferred? And then do we know that, and are we communicating with that hospital saying, hey, we want that patient back. Please make sure you send us information. And then our care management, and I know we're going to talk about this a little bit more in depth right after me. So I'm not going to go a whole lot into this, but really looking at what's the patient's goals. Are we helping them to achieve it? Are they on any kind of medication? And are we helping them to manage it? And are we making sure they're having their follow-ups? So my doctor, love him to death, but I have to see him a minimum of once a year, otherwise he said he will drop me. Even though he likes me and he's my friend outside of work, he would drop me as a patient. And I'm like, So, but that is set in practice. It's something we know as patients with him. So again, it's helping keep the care management concise and that our patients keep coming back and we have that relationship. And then we have patient self-management, problem solving. My problem is I don't drink enough water. I know how to solve the problem, I just choose not to. But how do we teach our patients to do that? How do we give them tips? The hypertensives, are we tracking with them? Hey, what's your blood pressure this week? Just sending them a quick text. Or if we're using the patient portal, just remind them, hey, tell us what your blood pressure is running. Is it high? Is it low? Are you swelling? What's going on? Are you gaining weight? Our CHFers, our diabetics, everything. We can use avenues to track and communicate with our patients. And then we really want to look at the lifestyle. Do they need to modify their lifestyle? What does that look like? I got to reduce my salt intake. Probably the 10 pieces of bacon I had this morning did not help, but it was crispy. So, again, how do we do that? Looking at the emotional support. This is hard. Change is hard. We understand that. And that's where we really need to think about what are we doing with our patients. We can't just keep having them come in, see the provider, and here's what you need to do. It's helping give them that support. And what does that support look like? Each patient is different. A patient is a patient. And my support that I need is way different than support Kate may need. And those reminders, those daily reminders, those daily phone calls, maybe some emails, periodic touch points, just check in. So, and again, looking at how can we be supportive of them? And it also helps us in reducing those gaps in care because they're engaged. They want to be engaged with their provider. And then looking at the referral to the community and what they have to offer. And this one I cannot say enough about. So when we think about our community support and we think about our social determinants of health, what they can afford, not afford, and Kate, what's the website for community resources? Aunt Bertha. And I can't think of it either. I knew Aunt Bertha. We need to, in our clinics, understand what the community offers, because our patients are going to need this. And they may not be able to pay for it or afford certain things with this. So when we think about our community programs, we had a patient that came in and she would be winded from the get-go. Her knees were bad. She was a little on the heavier side and she was tired and we knew she needed assistance. We got into community resources and found out the Elks had a group from the high school that will build ramps for seniors. And they built her a ramp and helped take care of that. And then maybe, PT will do a fall assessment or a balance, test for her to see what can we do differently. And again, it's really enhancing your community. Not everything comes from us as doctors. It comes from the community support. We live and breathe rural. Let's embrace our communities and what they have to offer and give everybody that support. And that, a counterpart of mine, Lisa, that I used to work with, she had a patient, and I don't know where this patient was, but her salt intake was horrible, and she was always swollen, short of breath, very similar CHF and a diabetic. And come to find out, when we sent a navigator over to her home, all she made was TV dinners. Do you remember this story? But that's all she could do, because that's all she could manage was the microwave. And so she would buy a bunch of TV dinners, and that was her meal for every meal practically. And so it's learning, how do we help? And I know care navigators is a total nother topic that I'm not going to go into. But if you want more information, we can explore that. But it's really getting into those homes, having physical therapy, occupational therapy, go and do a home assessment, a home eval, to see how we can help these patients. And then we look at our resources. We get on Aunt Bertha and we find out that the Elks has some things to offer. The church does. Findhelp.org. Thank you. Findhelp.org. That is nationwide for any community. So please note that and let your staff know that if you are looking for resources. And again, your churches will do a lot as well. So ask your patients, are you a member of a certain church? It's good to know these things. And they may not ask their church pastor for help because they don't want anybody to know that they need help. And that's something that we can be open to because we're safe zones, in the provider's office. They most often tell us anything, especially the nurses. They'll tell the nurses a little bit more, and then sometimes they only tell the provider, no, I'm only here for one thing. And then the doc comes in and it's like this, and this. So again, get them to open up. Look at how you have communication. Yes? Yes. And that is huge. What they tell the front desk is way different than what they tell the back people. And if you have a triage room, what you hear in triage is not what you hear in the room, the patient exam room. So it kind of grows. It's like a spider. It just kind of feeds out a little bit. So again, understand what you have to offer in your community. Now, I have been to some communities that have nothing. It is very nominal. So you look at some of your outside, that primary market area. So it may not come from your community, but it may come from your market area. So look at that primary market area. And if you don't know your primary market area, holler, and we'll help you to find that and look at that. So access to care. So when we think about access to care, that they can see their primary care provider at any time. Is what we would like to think that we could do. But it's really looking at your schedule, offering different available options, always having same-day appointment options for your patients and how you do that. So when I think of same-day appointments, I try to think about, okay, what's the best way to fill those? And I was in a clinic one day, and I was asking them how they did theirs, and when they have their open slots for sick patients. And they fill theirs from the back forward. So starting at 11, they come down to their 9 o'clock start time. And they start at that time. So that way, if the morning is still fairly open, that gives them time to go through medical records and get the patients ready and make sure the records are, they have all the information they need, or the provider needs a little bit of time to finish up charting or something like that. And then on the flip side, from lunch, they go backwards, looking at like about the 4 o'clock time frame, and they keep them open up until 3, and then, looking at that fill space. So again, it's just different in how you do it. Timely clinical advice. There's nothing worse than getting information you needed 2 weeks after you needed it. And when I think about this, when I think about timely advice, I have a patient that comes in and we want to give them some information. We want them to get into the specialist, and it comes so late. I can tell you, it takes months sometimes to get into some of these specialists. How do we help them in the interim? What can we do? And looking at what kinds of education, resources, any kind of therapies, anything like that that is available. We can't expect that to just fall on the specialist's hands. We really want to give them something that helps them now to get to the next step. And then continuity of clinical information. If it's not documented, it's not done. And what did the patient say? When we think about clinical information, we want to make sure that we are charting everything. And this is really important when it's a different nurse, especially if you have travelers or PRN staff that are coming in and working in the records, and they can't see the story. And that is the biggest thing is, if you open my medical record, can you see my story? Can you see what I have going on in my lifespan, and, just kind of what are my medical needs right now? So population health management. So this one's, is anybody part of an ACO? Part of an ACO, anybody else? So this is very common in our ACOs. It's completing our registries. We have a hypertensive registry, a diabetic registry, maybe even a cancer registry. Looking at how are we helping these patients and controlling their chronic diseases, our CHFers, our COPDers. What are we doing for them? Are we helping them to monitor their pulse oxes, their weight, looking at those fluctuations in weight? And, how are we keeping tabs on them, that they're coming into the clinic, and making sure that they're being seen? This is all using that data, and again, EHRs can be a love-hate relationship depending on which one you have. Can you pull the data? Can you abstract it? Are you using the right codes? Are you filling in the right boxes? Are you checking the box to make sure that it calculates into your data and your data mining when you start to go look at your records? And that's something where, you really want to have an informatics specialist, help you build your tools to work for you. There is nothing worse than getting an EHR system and come to find out it's not doing what they promised. Well, it's extras that get added on, or you have to do it yourself. And it's like, well, if I have to do it myself, then help me, and ask for that help, and make sure that those vendors give it to you. Oh, electronic health systems, yes. They're so much fun, but really looking at how often are you running your reports? Are you looking at them routinely? When we do our program eval, we have to run reports and look at our data, but how often are we really evaluating those codes? Are those really our top 10 codes that we are using as our diagnosis codes? And then if it's chronic diseases, what are we doing about it? What does the data tell us? And that is, I specialize in quality, and I look at, I have all this data, now what? Do something with it. And it doesn't have to be robust. You don't have to have an expert in there. Just look at it, evaluate it, and say, yes, this is what we're doing with this. Or this one, it doesn't make sense. Why is it triggering? And start looking at what we're doing. How often are we using e-prescribing? How often are we using email or text messaging to our patients? Do we have a system in place? One of the things I'm going to touch on briefly too is our phone systems. And I know it's not in here, it's not part of PCMH, but our phone systems need to be easy access to a person, not 10 choices before you get to somebody. And that is something I do want to strive, because a lot of them will get frustrated and either hang up or just walk in the office. So we want to make it convenient, and technology can be a good and bad evil depending on how it's utilized. And we want to talk to our patients. Yes, you have a cell phone, but do you text? Can you read the texts? You have a patient portal, but I have no internet. So what good does it do me? How can I access that information? Maybe I need my information mailed to me, extra education periodically. Put it on a postcard, send it in the mail. It doesn't hurt. If they can't access their patient portal, it does you no good. Measuring and improving. So again, we have all this data. We have all of our information. Now what? What are we going to do about it? What kinds of information are we wanting to challenge our staff with in improving? And then looking at the effectiveness of what we put in place. So I teach a lot in lean and lean process, and I'm all about lean. I'm not about Six Sigma, but, when we think about lean, we want it simple. Kiss it. Everything you do, kiss it. Keep it super simple. And make it stick. That is probably one of the things that is the hardest to do, is to keep it sticking where it needs to. That staff are staying on top of this and managing this. Looking at our performance data and saying, okay, did we meet our target? Are we on target? Are we slipping backwards? And how are we doing that? When I do mock surveys, a lot of times I'll talk to staff at registration and say, tell me about your consent process. How do you get your consent signed? Oh, this is how we do it. And they walk me through a process. I said, but your policy says you do it this way. Yeah, but that's just the policy. This is the way we practice. So if our policy says one, but we've found workarounds to do it another way, which way's right? Policy. Policy wins every time. So again, make sure that your processes are sticking and they make sense. So if they don't make sense, then, maybe we need to look at policy and rewrite it to make it work. Again, it's a matter of give and take, but keeping it simple. Share our performance with the providers and publicly. When I worked in a hospital that was owned by CHS. It was a for-profit system, 175 bed. I was chief operating officer. We stutorized ourselves. And if you've ever gone through that process, it's so much fun. And then they say, put your data on the wall. That horrified me. I'm like, you want me to do what? Put our data on the wall and show them. And I'm like, okay. So we did. It wasn't pretty. Our data didn't look the best, but it was there. And it was in front of everybody. And I have to tell you, I had an ER staff, and one of our quality metrics was on there, and it was ER turnaround time for a stat of, I think it was a CT stat. And they owned that. They said, we don't want our department in the red on that board because everybody sees it. And they truly believed they were the front door of the hospital. They embraced that philosophy, and they knew it. And they changed, and they got it done. They literally went over to the radiology department, put a team together, and fixed it. How can we make this better? How can we improve our numbers? So when you start putting things out there publicly, staff start to see it and say, hey, we don't want them to know that. We're sharing our dirty laundry here. Now let's make us proud, and show where we're going. I started an HCAHPS vendor program when I was with ICANN. And one of the things that was, sharing your HCAHPS scores. No different than sharing your PCMH patient satisfaction scores. It's, here's where we're at. Would you recommend? That's probably the number one question I think we should look at. Would you recommend, yes or no? If you're not going to recommend us, then, I'm doing something wrong. Everything else is mud if you're not going to recommend us. So we got to get to that point, and start looking at it. And if we start sharing it and we start telling patients, hey, we want your opinion because we want to be up here. We want to be at the top. Tell us what we can do better. Give us suggestions, give us ideas, talk to us. Talk to your patients. Again, that patient-provider relationship. How can we build that? Benefits. There's all sorts of benefits of PCMH. There's some up here, but it's the right thing to do. It is the right thing for your community. Whether you get recognized or not, I don't care. It's the framework and the process of what you do in your clinics for your patients. This is, patients under medical home, care coordination, quality measures, gaps in care. You're addressing the whole patient and sometimes their entire family. So again, it's just looking at how can we be provider of choice for our patients and the community. We want them coming to us. We don't want that out-migration to tertiary cares. And if they're seeing specialists, we still want them to see their specialists, but we want to be their primary. We don't want them to always go to their internal medicine doc, down the road. We want them to come to us for their needs and then their internal medicine for their CHF. That's what we want to embrace. And looking at, that patient satisfaction. Are we meeting their needs? Are we capturing their needs? Are we asking them? So staff role. Staffs are patient advocates. They need to embrace that. They need to tell the providers, what the patients are telling them. If it's something maybe a little bit different. Well, I wasn't going to bother the doctor about this, but, I've had this pain. So, essential member of the team. Staff need to embrace this as, it is important that everybody works together from front office to back office and all in between. Even housekeeping can play a role if you have housekeeping on a day-to-day basis in your clinics. So, and then sharing ideas to improve patient care. When you have your huddles in the morning, start talking about, what did you do yesterday? What did you learn yesterday? What was your bottleneck yesterday? How can we improve that today? How do we start to embrace all of us as a team and looking at it? And then, working to your highest level of education. And that's what we definitely want to do with all of our staff is, working them to their highest capabilities. All right, I said I'm going to talk about two, NCQA and the compliance team. So NCQA, you can see up here. Is anybody ever gone through NCQA? You guys have? So, I like NCQA. When I first started looking at PCMH, the compliance team didn't have one, and this is what we used. This is what we were looking at. I think we looked at them, and BizMed, I think, was the other one that we had. So again, it's a recognition program. The one thing about NCQA that I will tell you I don't like is it doesn't give you that personal touch. It doesn't evaluate, how does this fit in rural? It doesn't say, here's my problems, this is what I'm doing about it, and this is how I fixed it. It doesn't come in and evaluate. And that's something I know we all are gonna learn about mock surveys. Having a second set of eyes come in and evaluate your program is huge. And NCQA is a paper program. It's send me all your data and show me what you've done. It's all on paper. I am a firm believer in looking at how can we, have somebody come in our doors and, say, welcome, come check us out. Yes. Yeah, they definitely do train you, and they give you the tools you need to be successful. So, and that is something I think that is a value, is having that PCMH coach, that person, that advisor saying, here's what, okay, let's look at this, this, and this, and having that program in place, and a step-by-step approach. So here's the two versions. We have NCQA and the compliance team, and what this just says is, they both really look alike. And when we think about patient-centered medical home, we really want to look at what are we providing, and, does it meet the needs of the community? Is it patient-focused, truly patient-centered? Are we capturing, I'll send you these, Kate. Is it truly looking at what steps do we need to take to be that provider of choice? Now, I will tell you, here's another downside to, and I'm really trying not to be NCQA downer, because I do like their program. I will tell you, I do like it. But I think it's best for bigger clinics. So each one of these 5 have a gazillion steps underneath of it. And that's the part you don't see. The compliance team, and God love Kate, and, I know, I'm not supposed to promote one or the other, but it falls in line with our state operations manual. Hey, we're a rural health clinic. This is what we should be doing. This falls right in line with it. This is how we do it. It looks like there's more steps because they have 9, whereas NCQA doesn't, but it doesn't, because each of those in NCQA has multiples under it. Whereas the compliance team, here's your 9, and here's a few steps of how we're going to measure you with that. It's straight up to the point, and it's straight up rural, and it benefits all of us. But our first steps, how do we really look at this? So I want to be PCMH. I don't really want to go through the recognition program, but I really want to embrace this model of care. This is who I want to be in my provider office. What does that look like? How do I start going down this journey? Identify a leader. And, a lot of times this falls onto the managers. I'm going to tell you, make it somebody in the back. Make it somebody that's doing the work as your team leader. And the reason I say that is because they're going to identify some other bottlenecks that the managers may not know about or hear about. And then, educate the team. This is the model we're going to go for. We hope our goal in 2 years is to get recognized. But for right now, we're just going to implement the structure and infrastructure of how we do things. And then we're going to look at practice readiness and, do kind of a full-blown assessment, kind of like the mock survey. And if you do a mock survey, and I know Kate's going to talk about that, or you do care coordination and implement that, all those pieces fall into this assessment and looking at, are we ready? And then we're going to create that plan. Here's where we're going to go. And again, I'm going to tell you, change is hard. So, and then we're going to look at, our health information technology, our data. What does our data say? What does it say we need to improve on? Does it say anything? Does anybody know how to read it? Is anybody looking at the reports, or we're just reporting numbers for numbers' sake because we have to our board? Again, really starting to prepare for that implementation of PCMH. So, and then we're going to go through our transformation. And we really want to have that vision. What does it look like? And when I was with ICANN, and I'll give you scenarios of this, we did the whole gamut of education. And then I said, now I want everybody to go up and put a mark next to each of these areas. And we did big white Post-it notes, my Christmas list Post-it note sheets. And mark up every area they think is going to be a bottleneck. And it was interesting because each clinic was always different on which one they thought was going to be a challenge. But that helped drive our vision because we were all engaged. We all knew where we needed to start, and we all knew the problem areas. So it started that journey and creating that vision of, so if we fix this, what will it get us? and that's where they started to interact and engage. And, sometimes it's just kind of fun when you see your entire team thinking about a process and all of a sudden that light bulb goes on and it's like, oh, this is what we get, and it's engaging. It's work, let me tell you, and they're going to be like, we got to do something else, we got to do more work, but it's not. It follows, function, the function follows flow, flow follows function, however you want to work it, it just starts to blend into their daily activities. Instill confidence, allow for failure. That is one thing that I think we forget to do, allow for failure, because we're going to have them, and that's okay. We've just got to figure out, how did we fail? It's not the why of it, it's the how of it. It's not a people person, it's a process problem, and looking at that. And then support the staff, and continue to talk about it and talk about the progress. Keep it up on a board in the break room if you have a break room, or a poster board somewhere, and say, here's our journey, this is where we're going. Have that deadline, and then start, how are we getting there, and inching forward. Your implementation plans, comprehensive, focused, time-oriented if at all possible, and then, really looking at, the integration of change, and making it stick, keep it simple. And then look at small elements. When we go back to, that list, and either one of them, either program, and we want to take on one, which one was the biggest that staff identified? Let's fix it first. And then there's challenges. Not all staff embrace this. Not all staff embrace change. We want to reduce our patient wait times, but our providers aren't playing well. Or staff isn't playing well. Or we have a lot of no-shows, or, our office ends up being closed. There's a lot of, challenges that we may face. Looking at care coordination with our specialists, we know that's going to be a challenge. We're going to call them up front and say, hey, we are continuing to use you as our provider specialist in ortho. We want to continue to refer patients to you, but we really want to be ensured that we're going to get reports back from you, that you're going to send us information. Look at utilizing nursing staff to the care management, and looking at our chronic care management plans and how we do that. And then fully implementing the electronic health records to build our quality reports. What's the data say? And then, continuously ask staff to evaluate the progress. How are they feeling about it? Are they embracing it? Do they feel it sticking? Because if you have a negative NILI, that's going to bleed throughout your entire organization, and we all know it. So some lessons learned, and I'm going to have Kate share a few that she has seen in her clinics. And I will tell you, I went with Kate to a clinic, and I think it was in Louisiana. In Louisiana? What clinic did we go to that we got wine that night? So in her house. But they had this amazing PCMH process. And it was a bigger RHC, but I'm telling you, everywhere you went in that clinic, the staff were proud of it. They embraced it, they loved it. You could see it. Their patient satisfaction scores bled it. They want to come to those providers because they're engaged. They listen to the patient. They take the time with them. The physicians and providers, again, they might not always be on board right at first. And so we start slow. We start just kind of integrating small steps of change. Looking at building our relationships, be creative. Really think outside the box, when we start thinking about what we're looking at, with the PCMH process. Our IT team, if you have an informatics person, make sure you can pull the right data. If you can't pull the right data out to see how you're doing, then you need to look at it differently and build something within your system. And a lot of times it's just checking the box to make sure that you've done things. So with the care coordination, may or may not need to add staff. I know we've got several people here talking about care coordination, and we have chronic care management folks as well. So if you need to look at staffing, please reach out to them. And then, you can't wait for everything to be perfect, and the time is right at any point. I know we're coming out of post-COVID. I know COVID's kind of creeping back, and now we have monkeypox, and, who knows what's coming next. There's always going to be something, so just make that step. That's the biggest thing. Start small. I don't care which way you want to go when you start it, just start somewhere. So lessons learned. Need to focus, prioritize, and sequence change efforts. Yeah, easier said than done. It sounds great on paper, doesn't it? So, and when we ask our experts here, we're going to ask them about that. Recognize that successful change happens through effective teams. Really look at your team management, building your teams. The 5 highly effective communication skills of a team, look at some of those things and embrace that. Look at how we do some of our conversations with our patients. How are we asking them, the right questions to at least get some answers out of them. Change fatigue is huge. And, we're tired. We're tired of being in masks. We're tired of COVID. We're tired of hearing about COVID. So when we're trying to implement something else, let's just make it a process of, we're trying to really build back our patients' trust and how we treat our patients to identify those gaps. And then, internal and external QI coaching. Change is hard. When we make the switch, what does it look like? The last one here, people fear change, loss, any change. I don't know how, but for some reason when you make a change, and they have been doing it this way, they've been in the practice for 20 years, and now you want them to do something different, they feel not just change loss, it's loss of identity of what they used to do. I've always done it this way, and it's helping them embrace that and look at that. And when we started PCMH in several of our clinics back in Illinois, we looked at that in several of our clinics as our first number one. What scares you the most about this? What is their fear? It wasn't looking at the process at all. We educated them on it, and then we said, what is your fear? And they said, we're going to go back to the way it always was, because this is the way we've always done it. How do we embrace it? And then as a team, we've recognized this. How do we address it? And how do we work with each other? Sustaining change is even harder. And we all know this because we always go back to the way we've always done it, or we hide things, and we kind of keep doing the way we've always done it, but we tell people we're doing it this way. Again, really looking at, how can we embrace this and make it stick? So, small changes. You don't want to take on all 9 tasks, of PCMH. Again, look at the one, and the one that stands out the most. Tackle the hard ones first, in my opinion, because take them head on and say, we are a team, we've got this, we're going to make it work. It's a marathon, not a sprint. It takes time. If you want to get recognized, plan 2 years. Look at it, embrace it, put everything in place, and then that next year say, come to my clinic. Let me show you what I got for you. And then summing it up, again, we want our patients to feel welcome. We want to be provider of choice. We want them to know anything they need can come from our clinic, our providers. That's our sustainability right there, is if our patients are embracing us. So how do we do that? What does that look like? When we market this, I'm not, and I don't really talk about marketing per se. I'm not a marketing person. I'm not a salesperson. I'm a nurse. And when you market this, you can put, I'm a PCMH recognized facility. That means nothing to the community. Market it of, we are your provider of choice, and we will make sure you have everything you need. That's what you want to market. That's how you really engage your community is, what are you giving me? It's not that I'm recognized by this. It's what's in it for me as the patient. So, when I go back to my clinic, Dr. Drew, they became PCMH recognized. He knows I work in the world of consulting, so he's always questioning me, how do we do? And, when I think about it, and I'm like, well, I kept getting these texts to drink more water after I seen you. And he's like, and how'd you do? And I said, well, I lied. I said, I'm up to goal. So, I got tired of the text. So he did talk to his group, and he said, okay, how can we embrace this differently? How can we look at it to assist our patients? But again, was it real? How can I help you, get to your goal? And what can I do as a provider to remind you of your goal? This is what you told me you wanted to get to. How do we do it? It's like your own personal coach without ever knowing you had one. You didn't even have to pay for it. So, how do we help our patients? How do we help our community? And they can see that. So, all right. So that is everything.